So hello everybody, in this video I'm going to talk about the pathogenesis and treatment of a very common ailment, a very common neurological ailment in our population, and that is migraine. Now we all more or less have an idea of what migraine really is. However, we often confuse it with other types of headaches. Now I'll talk about the diagnostic criteria, but a few basic features which I'm sure all of us are familiar with is that it is an episodic headache, and it is more commonly seen in females who have their first attack during their adolescent years or during that period of schooling, that is from 10 to 15 years of age. Okay, that is where they have their first attack, and after that there is progressively increasing frequency and severity of the attacks. Now this is the complete uh, classification of the different types of migraine. Okay, so it's not just simply uh, one entity, it encompasses many different clinical forms. However, I want you all to focus on two things. One is this migraine without aura, and this migraine with aura. Migraine with aura is the common migraine, which is found in approximately 80% of the population. And then there is the migraine with aura, which is found in 20% of the population. So without aura in 80% and with aura in 20%. And what is this aura? So basically, aura in migraine has three facets. One is a visual facet, one is an auditory facet, and one is a sensory facet. This aura actually precedes the headache, and visual auras involve seeing zigzag lines, fortification spectra, and there can be scintillation scotomas as well. And sensory auras may include tumbling and numbness in the hands which spread proximally. Okay, an auditory aura means you're hearing a very low frequency buzz or things like that. So these are the different types of aura that you may get in migraine. This aura precedes the migraine, the aura precedes the headache, and the headache is usually unilateral and is frontotemporal. Later it may progress to a holocranial headache. However, has a typical throbbing nature and lasts typically from 4 to 72 hours. Okay, usually it resolves within 4 to 10 hours, but the textbook definition is 4 to 72 hours. Okay, if it goes beyond 72 hours, then we have to consider an alternative diagnosis. Okay, so female who has her first attack during her adolescent years, aura, unilateral headache, frontotemporal in origin. It may be retroorbital as well. So frontotemporal is much more commonly seen than retroorbital. This throbbing in nature. There may be associated nausea and vomiting as well, and also photophobia and phonophobia. If in your houses your mother or your sister has migraine, you will see that during an attack she will most commonly retire into a quiet room, keep the lights off, and try to take rest. Okay, so and she will scream out if you shout or if any loud music is played, or you walk into a room and switch the lights on. So that is a very common presentation during an acute attack of migraine. Okay, right. So we must know about the pathogenesis of migraine, because it was only after understanding the pathogenesis of migraine was the clinical therapy were we able to institute the clinical therapy. Now, though it's still a very gray area for us, however, we have more or less zeroed in on the fact that its origin is from this trigeminal-vascular complex. Okay, what happens is that there are these meningeal vessels. Okay, so when there is an acute attack, at first these vessels go into a vasospasm and they vasoconstrict. These signals are relayed to the TCC, that is the trigeminal cervical complex. From the trigeminal cervical complex, efferents are related to the sphenopalatine ganglion and also to the thalamus, the hypothalamus, and the nociceptive input to the trigeminal nuclei are modulated by these three things: the locus coeruleus, the magnus raffinucleus, and the dorsal raffinucleus. These three modulate the nociceptive input to the trigeminal nuclei. Now, the stimulation of this hypothalamus, as you know, the hypothalamus is the highest regulatory body for autonomic functions in our body. Okay, so stimulation of this hypothalamus is responsible for that aura and for the autonomic features. Actually, the aura is seen only in 20% of the population. However, if a patient gets that aura, then immediately he or she must institute the acute management procedures. Okay, because after that, if once the headache has started, it becomes rather difficult to control the intensity or the severity of the headache. So once he or she gets the aura is preceding the headache. So once he or she gets that aura, she should immediately institute the acute management therapies. So from this sphenopalatine ganglion, nerves further go back to these meningeal vessels, and over here they release a chemical that is CGRP, calcitonin gene related peptide, and all these neural connections in the trigeminal-vascular complex are primarily serotonergic. So we devise therapies, or rather scientists devise therapies where they inhibit this serotonergic pathways. Now, as you know, serotonin in our body has 7 receptors, of which, excepting 5-HT3, the rest are all G protein coupled receptors. Only 5-HT3 is an ionotropic receptor. Now, 5-HT1B and 5-HT1D are presynaptic autoinhibitory receptors. They are similar to the alpha 2 receptors found in the sympathetic system. So stimulation of these 5-HT1B or 1D receptors will actually inhibit the serotonin release and inhibit this pathway. Okay. So 5-HT1B 1D agonists are our mainstay of treatment during an acute attack of migraine. Okay. And the CGRP, now recently CGRP antagonists have also come into a market. So even if you institute therapy very late during an acute attack with these antagonists, they are very useful as well. They are useful in the prophylaxis of migraine as well. But these are very new therapies. Unfortunately, many CGRP antagonists, the GPANs as they are called, like Telgage-PAN, their trials had to be stopped because though they showed very good efficacy in controlling the migraine headache pain, they had very high incidence of hepatotoxicity. I'll discuss it later. However, the CGRP monoclonal antibodies have shown very good efficacy as a prophylactic measure against migraine. Okay, so that's with regards to the pathogenesis of migraine. Sorry, one thing I forgot to mention. After the release of this CGRP, this is when the blood vessels, the meningeal blood vessels dilate, and there is meningeal edema, there is stretching of the dura. As you know, dura is one of the pain sensitive structures in our cranium. So this is stretching of the dura, and hence there is the onset of the pain. Okay, so stimulation of the hypothalamus is responsible for the aura, and CGRP mediated vasodilatation leading to meningeal edema is responsible for the headache. So that's the complete pathogenesis of migraine. Right. So this is a very simplified diagnostic criteria for migraine, which you can find in Harrison's 20th edition. So as they say, repeated attacks of headache lasting 4 to 72 hours in a patient with a normal physical examination and no other reasonable cause for headache, and at least 2 of the following features: unilateral pain, throbbing pain, which is aggravated by movement and is of moderate or severe intensity and has at least one of these following features as well: nausea, vomiting, or photophobia and phonophobia. Okay, so that is the diagnostic criteria, and this timeline is very, very important. I am not discussing other types of headaches, but please note that if this goes beyond 72 hours, then it cannot be migraine. This is definitely not migraine. And there is this Midas questionnaire, which is used to assess the disability which is associated with migraine, and there are these 7 questions, and then we calculate the total and assign a grade. Okay, so this was first published in 1997. Right, so that's a brief introduction into the topic of migraine, and now let's slowly move on to the pharmacotherapy.